For the families, friends, and patients with terminal illnesses, dying can be a difficult process. Fortunately, there are people who can help us move through the process as comfortably as possible. Please stay with us as we discuss hospice and palliative care, the bridge over troubled waters, next on Kentucky Health. In her 1969 book on death and dying, Dr. Elizabeth Kubler-Ross described the 5 stages of dying. They were denial, anger, bargaining, depression, and acceptance. Not everyone will go through all 5 of the described stages, and those that do may not go through each one in a sequential fashion as described. However, more often than not, in some form or fashion, these emotions will be expressed. When we, the living, look at the dying patient, we must remember that though we are losing a patient, a treasured friend, a loved one, or a family member, they are losing everyone. Some of the concerns of both the patient and their family members include whether the patient will die alone, will they be in pain, and will they be able to maintain their dignity. To address these and other topics around the caring for terminally ill patients, we have as our guest today Dr. Dustin Dillon. Dr. Dillon earned his medical degree from the University of Louisville School of Medicine and completed his pediatric residency and fellowship in hospice and palliative care at Northwestern University. He is the senior physician of hospice and palliative care at Hospice Health. Dustin, thanks for being with us today.
Excited to be here. Thanks for having me.
You know, it seems to me, well, first off, tell me, what does it really mean when we talk about hospice and then palliative care? What's the difference and what are the similarities?
Yeah, I think that's a good question that a lot of people in the community and then also the medical community have. And I think when we think about palliative care, a lot of people equate that or make it equal to hospice, and in truth, they're very, very different. Palliative care just means an extra layer of support for patients and families that are facing some sort of serious or life-limiting illness. And this can be at any point along their disease trajectory. So let's say they were just diagnosed with cancer, palliative care is there to help. Let's say they have COPD or heart failure or dementia, palliative care is there to help. And we focus not only on the physical aspect of disease, like how the patient feels physically, but we also focus on how they are doing emotionally, spiritually, mentally, psychologically. And we focus not just on the patient, but on the family as well. So when you were talking about Dr. Kubler-Ross and mentioning how families and patients traverse this journey, they go through this process, we focus on both the patient and the family along the lines of palliative care. Hospice is palliative care, but for patients at the end of their life, in the last 6 months of their life. And so I think a lot of times when people hear palliative care, they immediately think, oh my gosh, hospice. And the truth is we have some patients in our palliative care program that we've been caring for years and may still have months or years to live. And our goal in palliative care is to increase their quality of life each day. We want to make sure they're feeling as good as possible, that they have their plans together for the future, talking about the what ifs, and that they have somebody picked out that can make decisions for them if they weren't able to make decisions for themselves. So I think it's really, really important that people know that you can receive palliative care for as long as you're alive, and that doesn't mean that you're in hospice. Hospice really is for folks that have a prognosis or a time of 6 months or less.
Why do we as physicians, I'm going to include me, but you know me and my colleagues, our colleagues, we seem reluctant or slow to pull in, particularly hospice, but I also think palliative care folks too. What's the problem? What's the block?
Yeah, so if you think about patients, you know, they're eligible for their hospice benefit through Medicare, Medicaid, or whatever their insurance is. They're eligible for that in that last 6 months of life. But if you look at the patients that receive hospice care, most patients only receive hospice care for about 2 weeks. So what you're saying is absolutely true, and we see it anecdotally, right? I mean, we get called from a doctor's office or from a hospital, and they say, we need your help. And then we go see a patient, and they're kind of in their final days of life where we could have helped them for months or even years prior to this. I think the reason that people get us involved late is this idea of hope, right? So there's this notion that if you involve palliative care or if you involve hospice, that somehow you're going to steal hope. And there have been multiple studies done that show that that's actually not true. And I rarely say that to families because when you start quoting studies, I think most people's eyes glaze over, at least mine do. But I think when we think about hope, hope changes along the course of our life, right? Yeah. And so let's talk about the cancer patient. Maybe their cancer has gotten worse despite surgeries and radiation and chemotherapy. And used to, they were hoping for a cure, right? But what we can do in palliative care and in hospice and working with the patient family, sometimes we have to reframe our hope. We have to change what we're hoping for. Maybe it's not that we're hoping to cure the cancer anymore. Maybe it's we're hoping to get to the daughter's graduation or the daughter's wedding. Gotcha. Maybe it's hoping for good time spent with grandchildren. Maybe it's hoping for good pain control and dying at home surrounded by their loved ones. So this idea that you're going to take away hope, to me it's actually a little bit silly because I don't think you could ever truly take away hope. I think we just have to reframe hope and talk about what are we truly hoping for right now based on where we're at. But I think that's the reason why most physicians, and again, we can blame everything on physicians because we are physicians. I think that's why they feel this sense of, if I bring this up, if I talk about palliative care, if I talk about, gosh, things are getting worse, I'm worried that I'm going to take away hope from the patient and the family. And in truth, I think that actually empowers them and gives them more hope to make plans for what's most important to them.
You know, that's an interesting concept that you raise, because so often patients say, at least I hear it, I want you to do everything that you can possibly do for me. And I question whether or not, and I don't mean to sound this as pejorative as it is against some of these pharmaceutical companies, but every night we see these commercials where a person, has an advanced stage, a lot of times it's cancers, advanced cancers, and they talk about using this drug, and at the very fine print it mentions the person who uses this drug versus the standard treatment lives an additional 4 months. But yet they show this person swimming, biking, they don't look sick at all. I mean, are we preying on people's hope when we do stuff like that?
Yeah, it's funny because I've seen those commercials too for various medications, and a lot of times it is cancer treatment. And yeah, the pictures they show or the people that they show, they're always on a beach, and you're like, well, why wouldn't I take that? Right. And the other interesting thing I think that we do in palliative care and in hospice, right, is we sit down and we figure out what is most important to patients and families, and we make a plan based on that. And I tell people all the time, I truly do not care what a patient or family decides to do, right? Their path and their decision is going to be the right thing for them. What I feel like my job is to talk about that path and what it truly looks like, right? So if we're thinking about, the next advanced cancer medicine, right, especially for somebody that has had multiple relapses or their cancer has come back multiple times, and let's say they're already spending most of their time in bed and they're not really eating and drinking much and they're just really, really weak. If they're going to choose to do another line of, let's say, chemotherapy or another medicine to try to treat their cancer, I think it's my job to say, all right, if you want to do that, I think that sounds like a good plan. Let's talk about what I think that's going to look like, right? And then realistically say, well, I think if you do this next treatment, it's going to mean that you're going to spend some time in the hospital. It's going to mean that you spend time going back and forth to the clinic and getting labs and things like that. There are obviously side effects of medications, and sometimes medicine can actually make you feel worse, right? And so I am not biased against any certain path. I just want patients and families to know what we think that may look like. A lot of times that's really important too, that myself as a palliative care physician, I have to collaborate with all of my community colleagues, right? So a lot of times I can say whatever I want, but they need to hear it from their heart failure doctor, or they need to hear it from their oncologist or their primary care physician. And so a lot of what I do is collaborating with our community colleagues and saying, hey, like this is what I saw and this is what we talked about in our home visit today. Where do you think we're at? Because I think pulling in somebody that knows the patient and has known them a lot of times for months or even years, decades, that carries a lot of weight with the patients and families, and so it helps them understand where they're at in their disease process.
I don't want to equate dollars and cents with life, but let's be honest. we have to look at dollars and cents sometimes. Just as we know that most healthcare dollars are spent on the last 6 months of life for somebody in an intensive care unit. And we also know that one of the leading causes of bankruptcy are health expenses. Does that ever enter into the equation, the patient's asking you, or you sit down and say, we can do this, this, and this, here are the costs, here's what the burden is going to be, not only the emotional, but the financial burden on the families? Not to say that, well, we want you to die so we can save money. No, obviously, never would say something like that. But does that sort of thing ever come into the equation when talking to people?
So it doesn't when we're actually talking to patients and families. I will say for palliative care and for hospice, it does help lower healthcare costs. And that's a result of good palliative care. All right. And so this is what I tell people all the time is that my goal is never to prevent a patient from going back to the hospital. Gotcha. So if we think about the heart failure patient, and they have frequent flare-ups of their heart failure, and they come into the hospital and they get, fluid medicine to help them get some of that fluid off. One of the things that I hear from patients a lot is I'll ask them, like, you've been to the hospital, 4 or 5 times in the last couple of months. How's that been going for you? Yeah. And it's funny because a lot of times I'll be like, well, used to, I felt really, really good when I went to the hospital, and I'd come home and I could get back to doing my life and doing things. But I've noticed over the last few times I've gone, it seems like I only feel better for a day or two. Gotcha. Right? And I think that sets up the ability for me or our team to say, gosh, I'm really, really worried about where you're at in your disease, right? It seems like your heart failure is getting worse. And so what that leads to a lot of times is if patients and families know that we can continue to go to the hospital over and over, but it's not going to make me feel better, a lot of times they're like, well, that's not the plan for me, right? So is there something else we can do to try to focus on my symptoms at home rather than just going to the hospital? And so this kind of brings up the idea of advanced care planning, right? And a lot of people are always like, what is advanced care planning? What does that mean, right? And so this is truly what it sounds like. We are planning for the future, right? So one of the things people always ask and talk about is a living will, right? And a living will just says, if I can't speak for myself in the future, what do I want people to know about me? And so people sign living wills or fill out living wills that says things like, if I'm hooked up to machines, whether that's a breathing machine or a dialysis machine, and I'm not going to get better, it's okay to take those things away, right? It gives them a voice, even if they're not able to speak for themselves. So when we talk about advanced care planning, that is one of the most important things that I do as a palliative care clinician, is to sit down with families and say, all right, maybe you're doing awesome now. Let's talk about the future. And if we get to this point, what would you tell us then? Or what would you say to us then? Because most people are like, well, if I'm not going to get better, I don't want to go on machines. I don't want to just be kept alive on machines. And so to kind of circle back around to your question about cost, I think when patients know where they're at, and this also kind of talks about openly sharing where we're at, I think they make decisions based on what's most important to them, right? And maybe that's not running back and forth to the hospital every time they get short of breath. Maybe it's, do we have medicine here in the home that can help relieve me or help my breathing here at home rather than going to the hospital? And we are able to prevent people from going back to the hospital a lot because that's their goal. So I think a secondary thing of palliative care, it's not our goal to keep people out of the hospital, but if we do good palliative care and figure out what people's goals are, a lot of times they don't want to be going back to the hospital. So in turn, that helps save costs. I'm going to come back to the advanced care planning in a minute. But picking up what you just said, though, a lot of times do patients, I perceive, now I must admit, I am projecting onto the patient, but when I talk about, okay, I think it's time for us to get palliative care or even hospice care, I get the feeling they feel we're giving up on them. Yeah, I think a lot of patients and families do feel that way. I've heard it, right? So the first thing I always do when I meet a family is I go in and say, I'm Dustin, I'm from the palliative care team, and I stop, right? And I watch their face. And sometimes it's that look you just gave and their eyes get real big, and sometimes they just look like they don't know what that means. And so I will ask them, have you ever heard of palliative care? Does that mean anything to you? And about half of people will say, yeah, my uncle was in hospice, or my mom died with hospice. And some people say, I've never heard of it. And I love the patients and families that have never heard of palliative care, right? Because I'm starting with a blank slate. And so that allows us to then say, all right, well, let me tell you what we do and what we're about. We're truly an extra layer of support because you got a lot on your plate right now. And the patients that I meet and the families I meet, they got a lot on their plate.
Wow.
And so I think, again, this goes back to that idea of reframing what we're trying to do. I tell oncologists and heart failure docs and PCPs, like, just because I'm involved or our team is involved, you also have to stay involved, right? Because you are just as important now as you were when we had all these different lines of chemotherapy that we had available. Maybe we don't have those things available anymore, but you can still be there for your patient and your family to treat symptoms, to talk to them, to help them along that journey, and patients want that. So I think you are right. A lot of times, I just had a family recently, and that's what they said. I feel like everybody is giving up. And I paused and I said, well, why do you feel that way? And she said, I just feel like other doctors think there's nothing else that they're able to do. And she's like, I just feel that. So I think we have to be really, really careful and cognizant of that as physicians to know what we're saying and how we're saying it, because we're never giving up on our patients. We're there for them along their journey no matter where they're at. Again, it just may be that we're trying to accomplish different things.
I remember once I had one of my mentors who happened to be a GYN oncologist who told me about an experience where he was at a dinner and this patient, a friend of a patient, came up to him and said, can you believe it? My friend was dying and all this doctor did was sit there with her and hold her hand. And he looked at her and he said, that's a heck of a doctor. Sometimes I think being there, not removing ourselves from the patient, we may not be able to do much. What is the difference with medical power of attorney and what you talk about the living will? Is there a difference? I mean, are these the same things?
Yeah, so when we talk about advanced directives, right, that's kind of like all the different forms that are involved. There are a lot of different ones. That just means this is a form that speaks for you and you can't. So a living will truly it talks about medically what you would want done to you. Part of a living will is at the end of it, and there are a lot of different living will forms that you can fill out with an attorney. And some of the language is actually really hard. I've read them sometimes, and it's like on this 17th day of the year of our Lord, 19, and I'm like, I don't even know what this is saying. Part of the living will, there's a part on it called medical power of attorney, or it may be called healthcare surrogate. Right? And so a surrogate is somebody that speaks for you if you can't. And so on that form, you can name somebody that knows you better than anybody in this world and that can make decisions for you if you can't. And so you can designate that person. A lot of people designate their spouses or their children, but not always. I tell patients a lot of times, I'm like, you need to pick somebody that knows you, that knows how you think, what makes you tick, but you also need to pick somebody that can carry out the decisions that you've already told everybody. So if you pick the son or the daughter that is not going to be able to stop the breathing machine if you're not getting better, maybe that's not the right person to name as your medical power of attorney or your healthcare surrogate. Maybe it is your friend across the street. But I think naming one person to be your person, that's one of the things that all of us need to do. And of course I laugh because people always say, well, Dustin, do you have a healthcare power of attorney? And I'll say, well, not yet, right? But truly that is something that all of us need. Like we all need a living will that talks about if something were to happen to us in the future, what's most important, and then the person to help make that decision if we can't.
Dustin, I think death is never good. Inevitable, yes, but it's never, we always want more time. I can't think of a more emotionally wrought experience than the child dying before the parent. So tell me about Courageous Kids. What's going on there?
Yeah, so Courageous Kids, and Courageous is with a K, so if anybody's Googling it, it's not with a C. Apparently there's a Courageous Kids camp that's spelled with a C, so it's Courageous Kids with a K. So that's the pediatric program, both palliative care and hospice underneath Hospice Health. So I'm blessed to be the physician for that team because I'm a pediatric palliative care provider. And what that is we're there to serve children and their families when they have some sort of life-limiting illness as well, right? And so right now we have almost 100 kids across our entire geographic footprint in our palliative care program. So these are kids that have different types of diseases. Maybe they have congenital heart disease and they have to have multiple different surgeries, and we know they're going to have ups and downs. Maybe this is a kid that has some sort of progressive metabolic disorder. We know it's going to get worse over time, and we know there's not a medicine to treat it, but we know that that kid's going to have a lot of symptoms, and we need to figure out what we can do to best support the family. So we have a ton of kids in our palliative care program, but last year in 2020, we actually took care of 22 kids in our hospice program.
22.
Right. And those kids died from different causes, whether it's cancers, heart disease, lung diseases. Maybe they had a stroke right after they were born and they've lived for, 15, 16 years. But your point about like, what is it like? Truly, I don't know. I tell this to parents all the time. Unless you've walked that journey, unless you're a parent that has lost a child, nobody can understand what you're going through. And I hear people sometimes in the rooms, and I know they're meaning well. They'll say, I can only imagine, right? But I think actually what they're trying to say is, I can't imagine. Like truly, I can't imagine, right? Yeah. And so just like in the adult world where we're there to serve the patient and the family along that journey, we do that in Courageous Kids too. And the important thing to remember about that is it's not just me. Like I tell people all the time, as the physician, I'm actually the least important person on the team. The most important people on the team are our pediatric nurses, our pediatric social workers, our pediatric chaplains, our grief counselors. Yeah. They're the ones that are focusing on all of the other things that go into taking care of having a sick child, right? Because most of the time these kids have 5 or 6 or 10 different medical teams. They have their heart doctors, their pulmonary doctors, their oncologists. I'm just another doctor. Yeah. But what these families don't have a lot of time is that other team, those other team members, right? That nurse, that social worker, that chaplain, that grief counselor that focuses on figuring out where they're at in their disease process and along that journey and making sure that we're serving that family.
You pointed out, what we're really saying, I got no clue what you're going through. So what do we say to the patient? What should we say to family members who are in hospice and palliative care when we come by and visit them? I mean, at the end of the day, you can't keep going, hey, how you doing? You're looking great. Or can you do that? I mean, what do we do?
I think you do whatever the patient and family needs. One of the things I learned when I was in training, when we were talking about like prognosis, like how do you tell somebody, like I think we're entering the last days to weeks of life. I remember the first time I did that, I was terrified, terrified. How do you come out and say that? And my attending that I was with, she said, well, you don't actually come out and say it. You ask first. And I said, oh, that's a genius idea. I never would have thought of that, right? Yeah. And so went in there and we started talking, and I said, one of the things I wanted to talk about was maybe how much time you have left. Is that something that's important to you? And they said, yes. I said, okay, well, that's important that they hear it. And the next question was, well, is it important that you hear that now? Do you want to talk about that right now? And they said, yes. And then the other question I learned is I said, well, do you have a sense within you of like how long you have? And they said, Doc, I really feel like I'm in the last days to maybe a couple of weeks. And that's exactly what I thought. And that's why I told him, I looked at him, I said, I think that's right. I said, that's what I think too, based on everything else that's been going on. And so this idea of like, what do we say to patients? I think we say whatever they need us to say.
So we as the friend, I'm the friend. Yeah. Whatever they need to hear.
Whatever they need to hear, truly. I'll share with this. I just lost my sister last year to breast cancer.
Sorry to hear that.
And one of the things, I felt like I was being her palliative care doctor, right? And I sat down with her and I said, Angel, I said, do you want to talk about all this cancer stuff? And she looked at me and she kind of rolled her eyes and she said, what do you think? I said, got it. And so after that, we didn't talk about all the medical stuff, right? Yeah. She could talk about the medical stuff with her oncologist. Right. But when I was there to be brother, right? So we would talk about how my dad was doing, how my mom was doing, how they were getting on her nerves, all those things, right? And so I figured that out just by asking those questions, right? What do you want to talk about today? And I think opening that up for folks that are going through this journey, a lot of times I think they'll tell you what they want to talk about. And maybe they do want to talk about their disease and how it's affecting them, but maybe they want to talk about what what Louisville or UK did over the weekend in the football game. So I think we just take cues from them. And that's really important too with kids, right? So everybody always asks, like, let's say you have a young parent that has some sort of terrible diagnosis and they only have a few weeks to live. Sure. Everybody always says, how do I tell my children that? Yeah. And that's a huge question. And I always say, well, are they asking questions, right? Because if they're asking questions about what's going on, clearly their mind is churning. And so I think we have to meet them where they're at and start exploring that with them through questions. So it's hard. I don't have the perfect answer to it. I've definitely walked into some of those families' rooms and I felt like I was an intruder, right? I felt uncomfortable being in this sacred space during that time. But I think we just explore what the families want to talk about.
Dustin, I really appreciate the sage advice that you provided us today. You've been a help for me. And I'd like to thank you for being with us today. I hope that you have a better appreciation of what a valuable resource hospice and palliative care can be and how it fits into the natural process of caring for the ill patient and family. If you wish to watch this show again or watch an archived version of past shows, please go to www.ket.org/health. If you have a question or comment about this or other shows, we can be reached at kyhealth@ket.org. Please be safe, considerate of your neighbors, and I hope that you sit down and plan for the future with all of your family members. And I look forward to seeing you in the next Kentucky Health.